A reminder before the next session, SLCIM publications are available for purchase at the registration desk, including SLCIM Past Test Series, SLCIM Guide, Symptom Analysis in Acute Medicine, SLCIM Guide, Humanness at Bedside. With that, we'll move on to the next stage. The next session is a multidisciplinary discussion on multispecialty approach to common clinical problems. I'm pleased to welcome the chairpersons, Professor Priyamali Jayasekara and Dr. Shamita Disanayaka.
Good morning, everyone. We are the second symposium of the day on multidisciplinary approach to common clinical problems. Without taking much time, may I invite our first speaker to talk on new life into COPD management. He is Dr. Amila Ratnapala, consultant respiratory physician at National Hospital Goal. Dr. Ratnapala, over to you.
Hi, good morning, ladies and gentlemen. First of all, I'd like to thank Dr. Krishant Jayasekara, the president of the Sri Lanka College of Internal Medicine, for the kind invitation to discuss about this topic of COPD, which is a very common and significant topic in the today's respiratory medicine. So these are my disclosures, and I'll be discussing about basics about COPD, and then why it is significant, and then how to approach clinically about this problem. So in come to the COPD Authority, that is a global initiative for obstructive lung disease, they define COPD as is a heterogeneous lung condition which is characterized by chronic respiratory symptoms due to abnormalities in the small airways or due to alveoli, which causing persistent progressive airway dysfunction. However, when it comes to our practical scenario, we know it is not a single disease entity. We know it results in a complex genetic, environmental interaction which is happening throughout our lifespan and leading to progressive dysfunction of our lungs. So this is a very nice paper published in Lancet Commission in 2022. Actually, our insult to the lung happened early in the years, before about 15 years before the diagnosed COPD. And then, actually, once the insult happened, we have a progressive loss of lung function, and we start gradual our symptoms. And the symptoms are progressing to a stage where the GOLD or GINA, whatever the authority, define as COPD diagnosis, where your FE1 to FEC ratio becomes less than 0.7. But at the time, a significant amount of lung function has been lost. Patient is significantly symptomatic, and thereafter disease progresses significantly. So, I mean, how? If we can start this early, are there any mechanisms, are there any ways to diagnose this early at the disease stage? And therefore, if they achieve that, we can achieve disease stability and we can reduce the progression of the disease. Actually, this is a study from Professor Ree from Korea, South Korea. I consider he as a father of COPD in Asia. And in this study, he found that actually the COPD is like a tip of iceberg. There are only very few patients who are diagnosed with COPD. But there are so many others who are compensating by themselves, and they are not having diagnosed COPD. They are on inappropriate treatment, either they are not on any treatment at all, and because of inavailability lung functions, because of mild symptoms, so the COPD is a tip of the iceberg. The problem is very significant than what we see in our clinics. So why it is very significant? Because COPD is a third leading cause of death globally. Not only in US, about 150,000 patients die annually because of this. It causes significant mortality as well as morbidity. This is another study actually done about disability-adjusted life years or years lost due to COPD globally. When you're at about 30 to 50 years, you can see about 15 million years lost because of the COPD. When you're at about 60s, it's about doubling, 30 million. At about 60s, it's about 45 million. So you can see the amount of life lost because of the COPD. If you consider the global prevalence of COPD, don't think smoking is the only cause of COPD. But as you can see here, and the etiology depends on the region. We belong to the Southeast Asia, as you can see here. the main reason for COPD is indoor air pollution in our part of the world. Smoking is not the commonest. So it reflects actually the study done in COPD by Dr. Kirti Gunasekara. It's a BALL study. It's a island-wide prevalence study done in COPD. We found that it's about 10.5% in our population. Male prevalence is about 16.4, and 57.1, majority of our females, our patients with COPD are non-smokers. So our genotype or phenotype of COPD is different to the world where the guidelines are coming from. So we have to make sure that we understand this properly. Not only that, we found that patients who had TB is more vulnerable of developing COPD. Now we are talking about COPD-I, where this TB as a cause of COPD. And we see quite a lot of this non-smoking COPDs in our clinic. So don't think smoking is the cause for COPD, and it is a significant factor, but still there are so many other causes that I'm going to discuss. Not only COPD has a single morbidity, the definition of multimorbidity is actually if there are two or more morbid conditions, disease condition in a single person, that is known as multimorbidity. But on average, we know about at least 5 morbidities are associated with COPD. So COPD is a multimorbid, the only one condition that has been labeled so far as a multimorbid condition. So when you're managing COPD, you have to manage at least 5 other conditions. Commonly, the cardiovascular disease, about 40% of the time, coronary artery disease, 40% of the time, hypertension, ischemic heart disease, cardiac failure, significantly associated with COPD. Why? Because of the shared pathophysiology as well as shared mechanisms. COPD not only causing a lung inflammation, it is causing systemic inflammation. It causes hyperinflation, therefore reducing the cardiac output, and also it can lead to hypoxia. So these mechanisms are leading to multimorbidity. So please remember, from here onwards, COPD is a multimorbidity. So therefore, don't stop your beta blockers when the patients are coming with COPD exacerbation. Don't stop your statin when the patients are coming with exacerbation, because it's a multimorbid condition. So then, when you consider this gold guideline on 2026 about COPD, we have to add that COPD is not a disease entity by itself. It is a complex genetic and environmental interaction, which is a process which is leading to severe disease over the time. So therefore, whatever the goal says, FEV1 to FVC ratio less than 0.7, that is good for your exam, but the disease started far beyond that. And remember, COPD is a multimorbidity as well. So we are dealing with the disease which has a high impact on survival and quality of life, and also which has a high impact on healthcare systems, and also it is potentially irreversible. And also, but still we can achieve stability. So when you are managing this condition, how we are going to manage that? First of all, we have to diagnose this condition. Well, the GINA, or the Global Authority on COPD, says that you have to have a spirometric confirmed diagnosis. That is a basic standard. But how many of patients do have spirometry availability in Sri Lanka or our part of the world? It's a very nice study done in Lancet. And as it is comparing the availability of spirometry, CT, and chest X-ray for patients with respiratory conditions. As you can see in the first graph, spirometry is available only about 50% of the population. In Sri Lanka, it is less than that. Whereas in CT scans, they are available about 70 to 80% of the cases. Chest X-rays are available about more than 90% of the cases. That is globally, you can see that in our part of the country, it is the case. So therefore, spirometry availability is a global issue. I mean, in our part of the region, it is not frequently available. So we have to consider other means of diagnosing COPD. So when it comes to COPD in Asia, we have quite a lot of problems. We have low availability of lung functions, low inhaler uses, high smoking prevalence, air pollution, biomass, low BMI, bronchiectasis, and tuberculosis as a cause, parasitic infections. There are so many things that we have to consider when you are managing COPD. So we have to deviate slightly from the global guidelines. So therefore, the Lancet, again, authors, actually, they suggested this approach for COPD diagnosis in our part of the world, where the symptoms and patients with high risk, and if the spirometry is not available, frequently, we can go for the imaging pathway. If the CT is available, we go for the CT scan. Even if the CT is not available, we go for the X-ray, and we go by the questionnaires, CAT score, MMRC score, and the frequency of exacerbation. Then we diagnose COPD as a probable COPD without spirometry in our part of the world. The GINA in 2026, about a few days ago, adapted this study, and they suggested actually that when there's no availability of spirometry, you can go for a questionnaire screening for COPD and come to a positive diagnosis. When it comes to COPD treatment, now we know how to diagnose. We are a poor socioeconomic country. We don't have the lung functions are available frequently, but however, we can use the clinical-based evaluation tools. When it comes to treatment, the GINA or the GOLD 2026, they suggest us to reduce the symptoms and reduce the risk of exacerbations on these patients. However, meanwhile that we are managing COPD to reduce the symptoms and reduce the risk of exacerbations, this trial, clinical trial, which is Fulfill, published in 2019, they gave us a new insight for the COPD management. What is that? Achieving disease stability. So disease stability is achievement of stabilized lung function, FEV1 less than 10% deterioration over 1 year time, no mild or no moderate or severe exacerbations over a year, and also symptom control of very well symptom control. If there are 3 domains, you can achieve the COPD disease stability. So this drug, which has been studied in Fulfill trial, a triple combination, which achieved the, you can see in the first graph about the St. George's questionnaire of the quality of life, how it is superior to the dual combination of drugs. And the second lower graph shows that the symptom burden of these patients are much less compared to the dual combination. So this is the way forward about triple combination of low-dose inhaled steroids. LAMA and LABA is going to change our landscape of COPD. So we are going to achieve the disease stability. This is a non-curable disease, but at least we can achieve the disease stability. So when you're coming to the management of COPD, it is very important to have initial assessment on these patients. So you do the spirometry or not, and then you go for a symptom score, assess the symptoms, and then you get the exacerbation history, whether these patients have moderate or severe exacerbation in the past, and whether this patient has a smoking status, whether they are current smokers or ex-smokers, and important the peripheral eosinophil count. And whenever it comes to our clinics, all the patients are having exacerbation. They're coming with their discharge cards. I'm always telling them, all the house officers and the registrars, they are very fond of writing the WBC count, the neutrophil count, but nobody is bothered about writing the absolute eosinophil count, which is our next surrogate predictor of the exacerbation, which is very important. So hereafter, please mind to write about the absolute eosinophil count in your diagnosis card, because that is a surrogate mark for COPD exacerbation. And then about the alpha-1 antitrypsin, which is not frequently available, and please take note of comorbid conditions and never stop the beta blockers, statins, or any aspirin or any other platelet inhibitors on these patients with COPD. Please consider this as a multimorbid condition. This is the GINA approach or GOLD approach. But in addition to that, in Asia, we have to ask about the premature birth history, because that these patients can have a low birth weight. When there's a low birth weight, that leads to poor growth of the lung. The poor growth of a lung itself is a predisposing factor for COPD in Sri Lanka and our part of the world, because the dose of exposure for this patient would be minimum compared to the other patients. For example, in Europe, they have a good birth weight and they don't have any intrauterine growth restrictions. These patients can absorb, or they can tolerate far more particulate material and far more polluted material than the lungs which has less growth or low growth. So therefore, in our history, it's very important to ask about the intrauterine life and about the possibility of low birth weight. In addition, we must ask about the indoor air pollution, which is the main cause of COPD in our part of the world. And you have to ask about the incense sticks, or the commonest cause, mosquito coils and other biomass fuel exposures in the indoor. Third is very important, asking about the TB, because TB is again one of the commonest causes of COPD in our part of the world. That is known as COPD-I. So ask about the history of exposure or history about any history of TB. It is very important because the management is totally different when it comes to TB-associated COPD. I'm not going into detail about that. And then when there's eosinophilia, but in our part of the world, we have to think about the parasitic infections, especially the absolute eosinophil count is more than 1,000. Don't ignore the eosinophilia thinking this due to COPD itself. And we see very mild eosinophilia in COPD. But when the eosinophil is high, it's more than 1,000, always think about any parasitic infections in these patients. So this is how we differ from GOLD guidelines in Sri Lankan setup. When it comes to the initial management, it's very important to go for the non-pharmacological management because we don't have the ideal treatment of COPD in Sri Lanka. We don't have the dual combination, we don't have the triple combinations, none. So what we can offer is the non-pharmacological management. The smoking cessation, even though we don't have the cessation program, at least discourage them on smoking and advising them against smoking, that is very important. The vaccinations. In COPD, 6 vaccines has been recommended, but unfortunately we do have pneumococcal vaccine, which is P23, which is not frequently available and time to time available. Influenza, which is recommended, not available in the government sector, but only available in the private sector time to time. COVID-19 vaccine, neither in the private sector nor in the government sector is not available. And if you can RSV vaccine, not available. COVID-19 vaccine, not available. Herpes zoster vaccine, not available. So these are the interventions that we can use to minimize the exacerbations of COPD. However, we don't have that. But still we can do whatever we can do. Actually, we can optimize the care with what we have at the moment. And the self-management strategies using the correct inhaler technique, and then the inhaler risk factor management, and managing their breathlessness. And most importantly, remember, we have to manage the comorbid conditions of these patients by the physician who's attending this patient. Right. In addition to that, we have to encourage their mobility. I know the pulmonary rehabilitation, which is the gold standard for these patients, not available frequently in our country. But still, no need of rehabilitation. Ask the patient to mobilize themselves. That is very important. If the patients are COPD treatment naive, in that case, we have to go for the treatment algorithm, which is suggested by the GOLD. If the patients are minimally symptomatic and they don't have any exacerbation in the past, you can use a bronchodilator. But if the patients are symptomatic without any exacerbation, that is group B, you can consider LABA-LAMA combinations, which is not available at the moment. When it is patients are having recurrent exacerbations, again, you can use this LABA-LAMA combination, that is long-acting beta agonist with long-acting antimuscarine, which is not available at the moment in our country. We have to use inhaled steroids only if the patients have absolute eosinophil count of more than 300. Or if the patients are getting recurrent exacerbation, we can use the inhaled steroids from 100 to 300. But never use high-dose inhaled steroids in this group because that is causing increased mortality and morbidity. Well, this is a very nice study done in UK. Actually, it's about the global availability of drugs, comparison with the COPD with cardiovascular drugs. You can see that most of the drugs actually which our cardiologists are using, they're using dapagliflozin, empagliflozin, and then sacubitril/valsartan. So all these advanced drugs are available with the cardiologist. But when it comes to the inhalers, quite unfortunately, we don't have the double combination, LABA-LAMA, we don't have the triple combination. That is, globally, it is the case. So this is a Lancet study about global availability of drugs for the COPD, which has a higher mortality and morbidity than the cardiovascular disease, but the drugs are not frequently available globally, not only in Sri Lanka. Again, that when the patients are having persistent dyspnea, you can consider changing of the inhalers, but currently, if the patients are getting recurrent infective exacerbation, you can use azithromycin as a prophylaxis. And if the patients are having chronic bronchitis phenotype with a fever less than 50%, you can consider roflumilast, which is not available at the moment in Sri Lanka. And again, that now we are talking about Th2 hyperinflammatory COPD. If the patients are getting frequent exacerbation with eosinophil count more than 300, we can consider biologics in the forms of dupilumab and mepolizumab, blocking their eosinophil pathways. But these drugs are not available in Sri Lanka. So when you consider in COPD, I mean, none of the drugs are available in COPD. One of the common condition, but none available in the moment in the market. So it's a very important study done about inhaled steroids versus pneumonia. You can see here, the fluticasone And the budesonide, the fluticon is the blue color one, the budesonide is a red color line. You can see that when you're increasing the dose of inhaled steroids in COPD, the risk of pneumonia is getting higher. The fluticasone has the very highest risk of pneumonias, which the risk is about 2 times and 3 times compared to the budesonide. But in the government sector, we do have the fluticasone inhaler at the moment. And then oxygen therapy and the ventilator support is again important in these patients, if it is indicated. Particularly, if the patients have resting hypercapnia, it is important to consider non-invasive ventilation, domiciliary in these patients. Just forget about all these guidelines and it come to practice in our part of the world. So we have to adapt our strategies according to our setup. So we are now talking about personalized care in COPD in lower middle income countries. The concept of treatable traits, it came from Portuguese actually in 2021. So now we are just forgetting about all these kind of drugs and inhalers. We are now go for the treatable traits. There are 3 main domains of traits. One is the pulmonary trait, extrapulmonary traits, as well as risk factor behavior. So we are going to manage them because we don't have the inhalers. We are going to manage individual factors. So these are the traits. There are eosinophilic airway inflammation in a pulmonary trait, bronchiectasis as a pulmonary trait, chronic bronchial infection as a pulmonary trait, airflow limitation as a pulmonary trait, lung hyperinflation, and chronic bronchitis. Extrapulmonary traits, actually obesity or sleep apnea, cardiovascular diseases, cachexia, anxiety, gastroesophageal reflux disease, and behavioral risk factors, which include poor inhaler technique, smoking and other environmental exposures, non-antiretroviral treatment and all. So this has been introduced, and also next we have to introduce the etiology on COPD in our guidelines. So COPD-I, COPD for infection-related COPD, COPD-C for smoking-related COPD, COPD-P for pollution-related COPD. So we applied this into our clinic. What we found, there are 92% of the patients with COPD are dyspnea predominant, but there are chronic bronchitis varieties, eosinophilic about 52%, and the reflux is about 68% associated with. Malnutrition, about 1/3 of the patients have malnutrition. And when you consider the behavioral traits, the past smoking, but unfortunately about 11% of our COPD patients in the clinic are still smoking, they are current smokers. So we can do quite a lot of things. We can see swirl lines in dark clouds. And also, domestic biomass in full exposure, ongoing exposure in about 1/3 of our patients. And poor inhaler techniques are about 25% prevalent in our clinics. So this is the model that I'm suggesting you to adopt to have a treatable trait approach for COPD. Irrespective of the indication, 100% of our patients are on inhaled steroids, and then therefore we changed our practice of COPD. We limited high-dose inhaled steroids in our practice. We started screening for extrapulmonary traits, and we are managing actively now extrapulmonary traits. And also we are introduced 2 nursing stations in our clinic to manage the behavioral states in our clinic. If I summarize my talk on COPD, just don't think about advanced drugs, which is not available in Sri Lanka, but 4M approach. Mentation, give a goal to the patient that why you are living and what is this target. We are going to achieve the disease stability of you. And mobility, ask them to do exercises, be mobile, and then manage the comorbid conditions. And then the medications, rather than prescribing medications, please de-prescribe the unnecessary inhaled steroids and other drugs which are intoxicating these patients. Thank you so much.
Thank you, Amila, for that very informative lecture, stressing all the physicians in this audience about the multimorbidity, therapeutic and management strategies. And we will take the Q&A at last. The next speaker is Professor Tashi Chang. I don't think that the audience needs any introduction. And he will be talking to us under a topic, From Symptom to Diagnosis, a systematic approach to headache evaluation. Over to you, sir.
Good afternoon. At the outset, let me thank the President and the Council of the Sri Lanka College of Internal Medicine for asking me to talk. So I'll be talking on a systematic approach to headache evaluation. And I'm sure no one in this audience would have not suffered a headache at some point in time. Headache is the most common outpatient presentation that one will see. The outline of my talk, there are 4 segments. I'm going to talk about the classification of headache disorders, then talk a bit on the common primary headache disorders. I will describe them to you. Then I will propose a 4-step approach to headache disorders, and then we will end it up by 4 illustrative cases so you can apply what you learn now in this lecture. And I will leave you with some clinical pearls to keep with you at the end of the lecture. So let's start with the classification of headaches, and together we will take the common primary headache disorders. The classification of headaches is very simple. It's just primary headache disorders or secondary headache disorders. Primary headache disorders are headaches where the headache itself is the disorder. There is no underlying disease. Whereas secondary headache disorders are where the headache is a manifestation of an underlying disease. For example, it may be a simple benign thing like a viral disorder where you manifest a headache. Or it may be something serious, sinister, like a brain tumor, where the patient manifests with a headache. Now, if you take the primary headache disorders, which is by far more common than the secondary headache disorders, there's a long list of primary headache disorders. I have listed only a few there. So you have the tension type headache, migraines, cluster headaches, and other trigeminal autonomic cephalalgias like SUNCT, SONA, paroxysmal hemicrania. And then you have the other primary headaches: exercise headache, sex headache, cough headache, stabbing headache, hypnic headaches, nummular headaches, you name it, it's there. So there's a long list of primary headache disorders. But the good news is 90% of your primary headache disorders are accounted for by just 3: tension type headache, migraine, and cluster headache. So that is what I'm going to focus today, because if you can master that, then you can diagnose 90% of the primary headaches that present to you. Now the key is the history, because in headache disorders, there are no investigations to diagnose. And signs are very minimal. So I will introduce the pattern to you so that with that pattern recognition, when you see a patient with a headache, you will be capable and empowered to diagnose those patients. So let's start with tension type headache. Tension type headache is by far the commonest primary headache disorder, and I am sure all of you would have experienced tension type headache at some point in your life. It is a dull bilateral band-like headache, usually in front of the head or right around the head. The patient may describe it as a tight band or a heaviness rather than a frank pain. The duration may vary from 30 minutes to about a week. The intensity of the pain is mild to moderate, and there is no aggravation by normal physical activity. So if you're having a tension type headache now, you still can sit here and listen to the lecture. If you want to engage in some sport activity, you still can do it with a tension type headache because it is not aggravated by physical activity. It is called a featureless headache because it has no other feature. There's no nausea, there's no vomiting, there's no photophobia, no phonophobia. So it is a featureless headache. So this is the pattern of a tension type headache. On the pattern, you diagnose. Once you diagnose, you treat. So how do you treat? It can be an episodic tension type headache where you get a headache once in a way. Simple paracetamol analgesic will sort it out. But if you're getting troublesome tension type headache almost every day, 15 days a month, going on for months and months, then a very effective treatment is low-dose tricyclic antidepressant like amitriptyline. Very cheap. You have to warn the patient, I'm giving you a tablet that is so cheap, it's like 30 rupees a month, but don't worry, it's effective. Because patients get worried when you give cheap medicine. They think you're not an effective doctor. So you need to warn patients then. Right, so that's all about tension type headaches. Now we move on to migraines. Migraines are more common in females. It is a headache of young people, adolescents and young adults. Don't diagnose migraine for the first time in an elderly patient. There's a genetic predisposition, so we do see genetic clustering, family clustering. It is typically episodic. Each episode may last 4 hours to about 3 days. What I mean by episodic is when you get an episode of headache, you're really knocked out in that period. and your next headache is say 2 weeks later or 2 months later, in between you're completely well. That is what episodic means. So if you can elicit that history, you know those are migraine histories. In children, be careful, the headaches are much shorter. It may be like 30 minutes or so. It is mostly unilateral. In 70% of patients, it is unilateral. It's not exclusively. Some people can have bilateral headaches. In 70%, it is unilateral frontotemporal region. It can be pulsating or throbbing, going zoop, 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 zoop inside your head. It is associated with all the features: nausea, vomiting, intolerance to light, which is called photophobia, intolerance to sound, which is known as phonophobia. It is moderate to severe in intensity. So much so, if you have a migraine now, you won't be listening to this lecture. You will be leaving the hall. It's made worse by lights. It's made worse by sound. And patient prefers to lie in a quiet, darkened room. Patient will be vomiting or feeling nauseous. So, and about 20%, that is 1 in 5 patients would have a aura. Now, auras are usually few minutes. They are about 20 minutes, never more than 60 minutes. And usually the headache follows within 60 minutes. The commonest aura is visual, as I have shown on that slide. On the topmost slide, it's called photopsia, where you can see flickering of lights in your visual field. Or you may see zigzag lines, that is called fortification spectra. Or sometimes suddenly this visual field, you see there are areas that you can't see. Those are scotomas. So in the bottom one, you can see visual scotoma plus fortification spectra in your visual field. So by far the commonest aura is visual. But the problem is there are other auras, like sensory auras. Sometimes patients become dysphasic. Sometimes patients develop hemiplegia. Or the patient might develop vertigo or monocular blindness. That is when the confusion comes in and you're not sure, is this a TIA or is this a migraine? And often patients get diagnosed with TIAs. Right, now we are going to look briefly at the pathophysiology of migraine. Why are we going to look at pathophysiology? Is because it will help us to treat patients, because that is the guideline on treating. You can understand the treatment. So let's look at it briefly. There is activation, what is called the trigeminal vascular system. Very simple. Your trigeminal nerve that innervates the blood vessels in the cranium. So why is the activation? There's genetic predisposition, there are environmental triggers, and so on. So when it activates, it causes the release of neuropeptides, calcitonin gene-related peptide, substance P, neurokinin A. So all these neuropeptides leads to what is known as neuroinflammation. Neuroinflammation is characterized by vasodilatation, protein extravasation, pain receptor activation, and sensory sensitization. Right, the sensory sensitization is what that causes photophobia, phonophobia, and also nausea and vomiting, and the pain, obviously the pain. So once you understand this schema, it is easy to understand where the treatment comes in. So if you use NSAIDs and antiemetics, that will counter the sensory sensitization and the pain. Then there are the triptans and the ditans. The triptans and ditans are 5-HT agonists. What they do is, they are vasoconstrictors, so they counter the vasodilatation. They also stop the release of neuropeptides. And then there's the new kid on the block, the CGRP antagonists, which target the CGRP, which plays a pivotal role in headache migraine causation. So now let's look at the treatment of migraine. So there are 2 stages of treatment. When a patient comes with a headache, you have to treat the acute headache. That is called abortive treatment. I said it is a episodic headache that recurs. So then you need preventive treatment, that is prophylactic therapy to prevent recurrence. So let's talk about abortive therapy first. Like we saw, NSAIDs and prokinetics should work in most patients. You can use the triptans, which are 5-HT 1B, 1D agonist. You have a long list of these drugs: sumatriptan, rizatriptan, naratriptan, zolmitriptan, elatriptan, all the triptans. Now the key there is that it has to be given at the very onset of the headache. It doesn't work once the headache kicks in. So you have to tell the patient, you need to take the triptan, you need to carry it with you in your purse and take it as soon at the very onset of the headache. And often patients know when they are going to get a migraine. Now the thing is, because it causes vasoconstriction, it cannot be given in patients with coronary artery disease, cerebrovascular disease, or uncontrolled hypertension. Now the ditans have an advantage in that they are also 5-HT agonists, but they are 1F receptor agonists, and they don't have the vasoconstriction that the triptans have. And the new kid on the block are the GPANs, which are the calcitonin gene-related peptide and antagonists. So there are agents that can be taken orally as abortive therapy in migraine. The CGRP antagonists also are used as prophylactic therapy, which we will come to. So that is your abortive therapy in migraine. When do we prescribe prophylaxis? If a patient gets 2 or more migraine headaches per month, then we consider prophylaxis. Now, if someone comes and says, "Doctor, I get a migraine once in 6 months," there is no sense in putting the patient on continuous therapy every day to prevent migraine in 6 months. So it has to be at least 2 or more migraines per month. Or even if one, if it interferes with daily activity. Now you take a pilot, that fellow can't cancel his flight. So even one migraine, if it's infrequent, needs to be prevented. What is our target? Is to reduce frequency and intensity. Some lucky people, the migraines disappear, but many won't. So you have to explain it to the patient. Other patients say, "You're giving me medication, my migraine is not gone yet." Yeah, it's not gone, but the intensity is less, the frequency is less. So that is your target. So what are the agents that we use as preventive therapy, prophylaxis? So there are multiple classes of medications, from beta blockers, angiotensin receptor blockers, tricyclic antidepressants, calcium channel blockers, 5-HT2 antagonists, anti-seizure medication, and anti-CGRP. Now, the ones that are highlighted in bold are the ones where there is class A evidence for its use in migraine. How these different agents act, no one really knows the mechanisms, but they're very effective. So which one do you choose for your patient? It all depends on the side effect profile of each drug and the comorbidities that the patient has. Now, for example, if the patient has hypertension, you would go for a beta blocker or ARB. But if the patient has bronchial asthma, you will not give a beta blocker. If the patient has obesity, then you will be selecting topiramate, because topiramate, as its side effects, causes weight loss and loss of appetite. If the patient is having insomnia, you will be giving something like pizotifene or flunarizine. If the patient is having anxiety, you might use a tricyclic antidepressant. So depending on the side effect profile, you make use of the side effect profile and the patient's comorbidity in selecting these prophylactic agents. And also we use combination therapy, so you can combine one with the other depending on the patient's response. Now, so the choice of preventive medication should be guided by the drug side effect profile and the patient's comorbid condition. Right, so that is all for migraine. Now we come to the last part, one of the primary headaches, that is the cluster headache. Cluster headaches are by far the most common form of trigeminal autonomic cephalalgias. Cluster headaches are called cluster headaches because they occur in clusters. So you will get daily headaches for several weeks, then it will stop. Then no headaches for weeks, months, years sometimes, or maybe never again if the patient is lucky. But they occur in clusters. And they occur same time every day, so much so they're called alarm clock headache. Sometimes 2 o'clock in the morning, the patient gets this severe excruciating headache. Usually women are more headachy than men, but this is the exception where cluster headaches are more common in men, and again in young men, right? It is unilateral. Now I said migraines are also unilateral, but migraines are temporoperator. Cluster headaches are retroorbital, it is behind the eye, and it is side-locked. What do you mean by side-locked? If you get a cluster headache on the right side, for the rest of that patient's life, it will be on the right side. It will never shift to the left side. It is side-locked. If it's shifting sides from right to left, then it is not cluster headache. It is excruciating pain. That cartoon beautifully illustrates it. You have a demon putting in a corkscrew into the eye. That is the sort of pain. Patients come, they are in tears when they come to you because it's so excruciating. Some are suicidal because the pain is unbearable. But fortunately, it is shorter duration than a migraine headache. It would last about 30 to 60 minutes. It is a trigeminal autonomic cephalalgia, meaning there are autonomic features. And what are the autonomic features? There will be lacrimation, redness on that side. I said it's side lock, so it is unilateral. So unilateral redness of the eye, tearing of that eye, and congestion of that same side. And some patients develop Horner syndrome. So you will notice in this picture, you will see that this man has tearing from his right eye. He has a partial ptosis and he has redness. So all telltale signs of a cluster headache. How do we treat cluster headaches? There's abortive therapy and preventive therapy like in migraines. There's also a transitional therapy because it's such excruciating pain, you need something more to treat these patients. So abortive therapy includes 100% oxygen. If you give, it's very effective, but not many people have access to oxygen. So we use zolmitriptan. The triptans are effective, but the point is the pain reaches its maximum within minutes. So no point taking a tablet and looking up. You have to give it intranasally or intramuscularly or subcutaneously to patients. Unfortunately, not many these products are available in Sri Lanka. You have the intranasal zolmitriptan if you need it. Transitional therapy is where we give a short course of steroids to patients, and that is effective. For preventive therapy, you will notice this is very different to migraines. We use verapamil, we use lithium. I have put verapamil in highlighted it in bold because that is the most effective preventive therapy. When you're giving verapamil, there are problems. There can be heart blocks, bradycardia, low blood pressure, and constipation. So look out for those. So that's all for cluster headache. And so I have told you 90% of the primary headache disorders I have described to you. So you should be able to diagnose that now. Now let's very briefly look at secondary headache disorders, and of them the sinister headaches. So I have listed some of the sinister headaches, which again can be classified as neurological or non-neurological. Neurological can be increased intracranial pressure due to a blood clot, due to a tumor. It could be CNS infection like meningitis, encephalitis, abscess, subarachnoid hemorrhage. So you can see that these are very serious conditions. If not intervened, the patient will die. Similarly, giant cell arteritis, glaucoma, acute hypertension. So now, if you are to recognize, you have to recognize each of these conditions separately. There's an easier way. If you can recognize the alarm signs of a sinister headache, then you can at least think there's something underlying. It is a secondary headache disorder. So what are these medically sinister features? So you can remember them as the SNOOP criteria. S is for systemic. So if the patient has fever, loss of weight, has a history of malignancy, or is on anticoagulation, you're going to think this can't be a primary headache, there must be a secondary cause. If the patient has neurological features like focal neurological signs, papilledema, neck stiffness, or seizures, there must be an underlying cause. If the patient has a thunderclap headache, thunderclap by definition is where the peak maximum headache reaches its maximum in less than 60 seconds. So that's a thunderclap headache. Again, you have to consider a sinister cause. If a patient comes for the first time with headache after the age of 50, always be suspicious. If the patient has never had headache in their life and coming for the first time after the age of 50. If there's pattern change where the patient has had headache, but he's saying, doctor, now it's very different. It's not the headaches I usually get. It's now daily, it's getting worse. Be very suspicious. So these are the SNOOP criteria for you to look at the secondary headache disorders. Right, now we come to the four-step approach to headache disorder. So we have learned about the classification and the common headache disorders. Let's look at the four-step approach. The first step is to identify the red flag. So when a patient comes, screen with the SNOOP criteria. If you find the SNOOP criteria, you can classify it as secondary. If you don't, it is a primary headache disorder. Primary headache disorder, your tool for diagnosis is history. Once you have diagnosed, investigate judiciously. If it's secondary, you have to image the patient. But if it's primary, don't image the patient. Be very cautious in imaging because that will cause problems. I will show you in the next slide. The exception is cluster headache, because in cluster headache, we image patients because a proportion of patients have pituitary tumors. So that is why we image cluster headache. And finally, of course, initiate appropriate management and follow-up. I have told you the treatments that we use in the most common forms of primary headache disorders. Now, neuroimaging headache. Now, the issue is there are incidental findings on the brain scan in about 1 to 2% of patients who present with headache which is unrelated to the headache. Now you'll see in this scan, there are white matter hyperintensities, which are marked by the arrows, that occur in about 30 to 60% of migraineurs. That has no, there's no increased risk of stroke or cognitive decline. However, these are diagnosed as ischemic foci, or they are called multiple sclerosis, demyelination, or they are told you have vasculitis. And the patient is put on antithrombotic agents, they are put on steroids, immunosuppressants, and this, the patient is getting worried because all this treatment and the headache continues because the headache has not been treated, right? And the patient becomes absolute mental wreck, anxiety plus, and the patient basically becomes vomit. So what is vomit? Victim of modern imaging technology. So be very careful about imaging patients with primary headache disorder because you cause more harm than good. And on the other hand, a normal scan does not rule out a sinister cause. For example, subarachnoid hemorrhage, you may have a normal scan. In meningoencephalitis, you may have a normal scan. So it doesn't rule out. So your clinical judgment is most important. We now come to the last part, which is I'm going to give you the cases and you're going to tell me the answers. Right? Just 4 cases. So put your think tanks on. I will read the case for you. Case 1, previously well, 35-year-old woman developed excruciating headache that came on suddenly while carrying her child. This was the worst ever headache she had experienced. It caused her to vomit several times. On admission, she was in severe pain and had neck stiffness. The rest of the neurological examination was normal. Blood pressure was 160/100. What is the most likely diagnosis? Anyone? Yeah, absolutely. Fantastic. SH. So there are other snoop things. Suddenly, it's a thunderclap headache, less than 60 seconds, right? Worst ever headache. And severe pain. And there is focal neurological sign, there's neck stiffness. So you have to do an uncontrolled CT brain and you can see the blood on the CT in the Sylvian fissure and in the cistern. So your pearl is sudden onset headache, worst ever headache is subarachnoid hemorrhage until proven otherwise. So remember that. Case number 2, 24-year-old woman presented with severe headache over the last 6 hours. She described the headache as throbbing. It caused her to vomit several times. On admission, she was in pain, but the neurological examination was normal, blood pressure 140/80. She described similar episode that occurred once in 2 to 3 months in the last 2 years. What is the likely diagnosis? Right, super. President is on a roll here. It's a migraine. It has all the features. Young woman, right? Throbbing in nature. Neurological examination is normal. But the key there is the patient has had recurrent headaches in the last 2 years and in between the patient has been well. So migraines are typically episodic. Okay? Case number 3, 27-year-old woman presents with a 6-week history of daily headaches, transient visual obscuration, meaning when she gets up, suddenly things go black and within seconds it's all right again. She has a pulsatile tinnitus in her ear. She hears shh, shh. Her MRI scan is normal. Her fundoscopic images are shown. What is the most likely diagnosis? Yes, super. It is idiopathic intracranial hypertension. A woman, again more common in females. Typical presentation, daily headaches, that's a Snoop criteria. We all get headaches, they don't go on daily, every day. It stops somewhere. In these patients, it don't stop. There are transient visual obscuration, that is odd. And pulsatile tinnitus, in the ear. So see, here the MRI is normal, so MRIs don't help to diagnose. It is your clinical judgment. Fundoscopic appearance shows papilledema. So your clinical pearl is fundus examination is mandatory in headache evaluation. We have seen so many patients who's been diagnosed as migraine and refractory migraine because no one has bothered to look into the fundus. MRIs don't help. And final case, 65-year-old woman presented with daily headaches for the last 3 weeks. It is a dull but notable headache associated with malaise. She also has noticed tenderness over her left temporal region. On examination, her optic fundi were normal, cranial MRI was normal, but ESR was 102. What is the most likely diagnosis? Yes, super. Giant cell arteritis. So here is an elderly person, headache coming late in life, 65 years old. Daily headaches, again a Snoop criteria. She has malaise, she has tenderness. They can point exactly to where the pain is. And the ESR is 100. So your clinical pearl is the 50-50 rule. Patient's age is more than 50 and the ESR is more than 50. You won't consider giant cell arteritis in patients below 50. So it is 50-50. And please remember this, high-dose steroids must be started immediately. The diagnosis is strongly suspected. Prevents irreversible visual loss. So that's the end of the lecture. So in summary, headaches are common and you are bound to encounter headaches in plenty in your practice. Headaches are classified simply as primary and secondary. I have given you the Snoop criteria. You rule out the secondaries, and then the primary headache is diagnosed on recognition of the clinical presentation based on the history. And accurate headache diagnosis is essential to guide our treatment. Without that, the patients are not going to get better. Thank you very much.
Thank you very much, Professor Chan, for that very interesting and important lecture. So we are moving headache to backache. So next lecture is about decoding backache, a clinician's roadmap from assessment to action. This speaker is Dr. Dominda Munidasa, who also doesn't need any introduction. He's a consultant rheumatologist in Rehabilitation Hospital, Ragama.
Thank you very much, chairpersons, for kind words of introduction, and thanks to the President and the Council of the Sri Lanka College of Internal Medicine for inviting me to be here today. Why back pain important? By age of 80, more than 90% of the persons are supposed to have at least one episode of back pain. And it is in countries where you have data, that is the most common reason for absence from work in especially Western countries, and it must be the same here. We don't have data. So it's important for any doctor to know how to decode the symptom back pain, and of course maybe trying to prevent vomit. So because that's the commonest problem that we get unnecessarily exposed to the imaging. Right, so it's very easy. It's 90% time it's mechanical. You don't have to go into too much detail, but there's 10% you may miss a medical cause. So medical causes can be many. You need to know that you need to have a systematic inquiry through your history and examination to exclude them, but there will be clues from the patient. As Arush said, if you listen to them properly, you will be able to get whom you need to go into details. So my task will be trying to make it simple for you, or have some sort of algorithm to look into when you get a patient with a back pain. So another important thing is, even if you don't do anything, most of the mechanical back pains will get better. Then why do we bother? Because these mechanical backs, the commonest form, will recur and can cause a disabling problem for the patient. Though you say, no issues, you don't have to worry, you are not going to die of it. But it's a problem for them, for their work, their families. So need to consider this problem seriously. And since it's a common problem, they will be coming to you with the diabetes follow-up, hypertension follow-up, and say, doctor, I have a back pain as well. So don't dismiss them there, and don't try to send him around. Try to evaluate yourself and see whether need any further things, or whether you can apply simple management. So how do you look at it? How do you clinically decode it? You don't go into the investigation straight away. It requires a very thoughtful, maybe well-arranged approach to the complaint. First thing that you need to sort out whether in your mind from your history and examination, whether it's medical or mechanical. And of course, look for the sinister features, which will show you there's increased CSF pressure or like something like Cauda-Equina syndrome. So with basic medicine, it's history and examination. That's how we go through this procedure. So there are a few things in the history just you to have a briefly look into. The younger ones, the commonest will be mechanical, the disc lesions and so forth. But don't forget they are the ones who come with early spondyloarthritis. If you miss it, they will have a problem by they become 50. Infections, then females, the endometriosis and things. The older one, again, it's more common to get degenerative spondylosis, but you cannot miss a malignancy with the secondaries, or like sometimes it's very rare, but it's abdominal aneurysm can present to you with the back pain, and it could be a disaster if you don't take it seriously. So how do you say that this is mechanical or medical? So mechanical pains, these few things you can ask in the history, generally worse with activities, especially with prolonged sitting and standing. They get better with rest. They improve with recumbency or lying down. Generally is worse in the evening, but better in the morning, and recurrence basis of with the same degree of activity. There are a few things you can just quickly ask from the patients and say, if these are positive, it's more likely to be mechanical than a medical issue. And when it's medical, like infections or inflammation, it's generally not related to your body position. And really they are worse in the morning with what we call early morning stiffness lasting for more than 1 hour. And they are worse with rest and better with activity. The medical ones also will have features like if somebody says, whenever I lie down, I have this worsening of back pain, can't sleep, you have to look into the possibility of a tumor somewhere or maybe sometimes infection. Those are the ones you have to pick and go for the further imaging and so forth. And night pain is again a feature of where the patient gets up middle of the night or early morning with a pain, a neoplasm has to think about. And of course, you have to ask about the constituent features of fever and others. So quickly going through them. So what are the sinister features which you have looked for? Increase, we have radicular pain lying down, especially if it's bilateral or especially with some neurological symptoms and signs. Pain increase with cough and sneezing, bladder bowel incontinence, saddle anesthesia, things that you will look into again, just emphasizing to this audience about the basic history and examination things that you should be looking for. That's how we decode this back pain. So again, family history, occupational history, and past medical history is important, looking for past neoplasms, what type of work they do, whether it's related to their work, postures, and so forth. And family history may be with the spondyloarthropathies. As I told you, a systemic inquiry into this is important if you have features to suggest whether there's a medical issue. Examination is one of the most important things again to find out. And it's just a routine. These cartoons tell you what to do, routine in a very quick way in your busy consultation in an outpatient. Generally, they come to you in outpatient. So look from the side. Look whether there is question mark posture, whether there's kyphosis. Look from the back to see whether there's scoliosis. And one way to detect the scoliosis, you ask them to bend forward and see whether there's asymmetry on the two sides of your back, on either side of the spine. And also when they bend, see whether the curvature of the spine goes down to a nice rounded shape from the usual, the normal standing posture of the width. And look at, they ask them to bend down, don't look at whether they can touch their knees, whether they can touch their ankle, or whether they touch their spine. Look at whether they can touch the floor or ankles. Look at their back, something which I see in MD exam spots. They don't look at the back candidates. registrars, please make a note. You miss how the spine bends. So if it's bent straight, that means there's a problem. So they are commonly the ankle-span patients. So if you have a rounded back when they bend, that means it's nothing in the spine. Bending backwards tells you whether there's an involvement in, when the pain worsens with that, there may be involvement, again, the spondylosis with the facet joints. Bending sideways, first sign of ankle-span. If they can't to lateral bend and touch their knees, side of the knee from the hand, that means a restriction, something very early sign of ankle-span in a young patient. Rotation and get them to walk, get them to toe walk, get them to heel walk, excluding your L4, L5, S1 lesions. So quick thing, you might, if they are all normal, you don't have to worry too much about sometimes this patient, but of course, there's still the look if there is any indication from the history. Then you, I went through that, looking for to look from the standing position. Then you look at the curvature, walking toe and heels, flexion, extension laterally, and this is what I'm saying. So this is a normal, call your spinal flexion normal, smooth reversal of the normal lumbar spondylosis. Different to ankle span, where you should be noticing there is very straight spine when they back bend. And then you do the shoulders and it will tell you that there's a problem. SLRT, a very simple test, clinical test that we do to see whether there's any radicular involvement. The positive SLRT test is pain running below, from the buttocks, going below, behind the knee, below the knee, to the calf at least, when you raise between 30 to 70 degrees. Before 30, it's a functional back pain. And above 30, above 70, it's more like to be a mechanical. So radicular one is you get a pain between 30 and 70, and it should generally get worse at that level when you try to flex your ankle or dorsiflex your ankle. So that's how you detect a positive SLRT test. Something need to be remembered in your quick examination. There's something called bilateral straight leg rest. We don't do much. It generally 0 to 70 will indicate there's a sacroiliac joint stress involvement. And do the physical examination on in supine, looking for your motor, dermatomal and motor weaknesses, just to see whether there's any radicular involvement, which need further investigations. And so lower limb neurological examination, the back pain is a very important part which you have to do. Sometimes if you think the back pain may be sometimes because it's nothing to do with the back, because they have a limb length discrepancy due to something in the lower limbs. It can be due to the hip joints. Remember, generally the hip joint pain comes in groin, not on your side or back or buttocks. So generally buttock pain, side of the thigh pain are due to back. So don't say hip pain there. Unlikely, but still you have to see the hip range of movement and see, and always look for the sacroiliac joint maneuvers. The straight leg test your L4, 5, S1, but if the involvement is higher, it is the what we call the femoral stretch test. Important to look for in a back pain with issues in your history and examination for cauda equina sensation. Just check the saddle sensation. That is where sometimes they might be where you get the clue that there is a cauda equina. So going through all that, you are looking at the mechanical, medical, whether there are any other sinister features. So therefore, how do you manage once you detect them? If you have sinister features, the cauda equina compression features, or history and examination detective tells you there could be a medical cause, and then those two definitely you need further investigation. The previous one, cauda equina, should go to a neurosurgeon quickly and let them do their MRI and they decide what to do. Medical causes is up to you to investigate further with the appropriate investigations. The the hematological and the radiological. Elderly, be careful because you might miss certain things. So what they say is above 50, do a ESR and a plain X radiograph of the lumbar spine, in spite of not having major issues. Younger ones don't run away with doing X-rays, so that will be vomit, I suppose. So X-ray normal, you do the MRI, so that is what became victim of the unnecessary investigation. Then, yes, so you exclude those, and even elderly patient ESR is normal, X-rays doesn't show major changes other than maybe degenerative changes. You can, if the mechanical is the cause, first 4 to 6 weeks, do a conservative therapy for all. You need to educate the patient about the posture and so forth, and control certain physical aid. It's not to the extreme of saying that you have a bed rest or sleep on a plank. Don't use your bed or sleep on the floor. That's not the constrained physical activities. Tell them what they can do. Bend, do things without bending the back. You bend from your knees and pick things up. Not to stay in, if you are working on a computer, so sit, but every 30 minutes, be little mobilize the spine and do things. And you give analgesia, give a NSAID if necessary. Muscle relaxants are important because most of the mechanical problems, the problem is the muscle spasm. So you have to relax that. NSAID won't do it, so you have to have muscle relaxant. And please start on your physiotherapy involvement. You get the physiotherapist to work on them. They can relieve the pain. They can do the posture correction advice, and they can do the strengthening and things to make it, to prevent further episodes. So those are the things that a physiotherapist should work on when you refer. So if you, and also it's important to downplay the illness behavior. As I told you, that's a commonest cause of non-attending work. So if you give a medical to them with the slightest thing and tell them to bed rest, it's going to be a problem. They'll sort of have the illness behavior used by them to get away from work. So encourage to resume normal activities as soon as possible. Get them that you don't have a medical, you have to go work. Maybe if it's severe, of course, you give some medical leave with the severe, giving your medications, but others need to return quickly as possible. End of 4 to 6 weeks, patient still having the pain, then we look at where the pain is. Whether it's, you have 4 categories there. Localized low back pain, leg pain below the knee like sciatica. The pain is on anterior part of the thigh, or pain is restricted to the posterior part of the thigh. And management depend on the patient group. So if you have localized back pain, the largest group, you just do the plain X-ray. Might show the spondylosis and spondylolisthesis and so forth. They can continue on their physical therapy with your analgesics and muscle relaxants. And still not responding after some time, of course, then you go ahead with further radiology investigation like MRI. Leg pain going below the knee, they not better by 6 weeks may need the MRI or CT or myograms to see whether there is a nerve or a root compression. If not indicated for surgery, still you can use with physical therapy. Epidural steroid injections are used, and then of course non-responders or having issues may, depending on the severity, may need surgery. Anterior thigh pain is not really back. You have to look for the hip diseases, inguinal hernias, kidney disease, femoral neuropathies, and other causes for pain coming, back pain running down to anterior thigh. Not better by about 6 weeks with your normal routine. So you investigate, therefore, on those lines. And posterior thigh pain is generally from, again, lumbar spine structures. It's radicular higher level, L2, 3. You manage your consent to continue. If not, again, you investigate to see if there's anything that needed intervention in surgical or other medical methods. So, ladies and gentlemen, whatever it is, it's in a systematic approach to management. Mechanical back pain need to be managed with increasing flexibility or by reducing the spasms, medical and physical methods, pharmacological and physical method. You need to strengthen the muscles around the prevention of further episodes. As I told you, recurrences are common. How you prevent is by strengthening as well as correction of biomechanics, including the posture. So that's the basics of managing back pain if it's mechanical. And so important thing again, I would like to emphasize the functional back pain. So it's easy to sort of recognize. They get tenderness to even superficial touch on the back. There are SLRTs from the, soon as you lift it, they shout in pain. Very inconsistent results in confirmed testing, like what I said, the SLRT. And it's not neuroanatomical structures are not followed in their features, and there's overreaction to everything. But important to recognize this and try to downplay their illness behavior, try to talk to them and try to see where the problem is. They may be trying to get away from somewhere. As Arosha said, is trying to get something the patient is, recognizing something the patient is not telling and finding facts beyond what they want to tell you. So that's all what I'm going to say. So in summary, it's a common problem, but 90% are back pain, mechanical, and you need to treat early to prevent chronicity and recurrences. And clinical evaluation through the history examination is what we were taught from medical students there, but keep practicing that rather than running into a quick investigating way of getting out of the patient, out of your room. And look for the mechanical or medical features, look for the sinister features, and further investigation done early if you have this cardiac pain or medical cause and elderly. Rest, 4 to 6 weeks of analgesia, physical therapy, muscle relaxation and activity modification. Important to downplay the illness behavior. And definitely prolonged rest is not indicated and not recommended at all. Try to get them back to work as soon as possible. And non-responders investigated according to those 4 types of areas of pain which is persisting. Thank you, ladies and gentlemen.
Thank you, sir, for that excellent lecture with practical approach and emphasizing the importance of history and examination, which is very much lacking in the younger generation. So because of the time factor, we don't have time for the Q&A session. Then on behalf of the Sri Lanka College of Internal Medicine, I would like to thank all 3 speakers for their excellent presentations. And also, I would like to invite Professor Priyamali Jayasekara, my co-chair, to deliver the certificates of appreciation. Yeah. Dr. Amila Ratnapala, Professor Tashi Chang, Dr. Duminda Munidasan, thank you.